a good thing because today is also, this week is, besides critical care week, this week is maternity sepsis week. So it's kind of comes into play. Although I wasn't saying I was enjoying this yesterday when I was putting some of this stuff together. Okay. So welcome. Glad you're here. Most of you know me already. I've been a nurse 37 years now. Majority of it was in the ICU, and I took the sepsis coordinator position a couple years ago, which has been a great change for me. So here we go. Maybe. Here we go. Objectives. I want to be able to make sure that you guys can review normal hemodynamic changes during pregnancy. We all learned back when in school, but when it's faced in a critical care environment, you kind of go, ugh. So identify risk factors. Of course, hit the Sears criteria for maternity and sepsis criteria, and then any ICU considerations for this pregnant mom and post-delivery mom. This is how I feel whenever you hear you're going to get a septic mom. So it's like, yeah, no, I'm sure obstetrics doesn't feel the same, but we do. Okay. So definitions wise, I'm going to back up just a little bit. The definitions for sepsis is the body's overwhelming and life-threatening response to infection, which can lead to tissue damage, organ failure, and death. Now, World Health says for maternal sepsis, it refers to sepsis that results from infection during pregnancy, childbirth, post-abortion, or postpartum period. It's a few facts that you might find interesting. There's 2.6 maternal deaths per 10,000 live births. Got to move something here so I can see. There we go. Black women are 3.3 times more likely to die from pregnancy-related causes. And American Indian and Alaska Native women are 2.5 times more likely to die. So it makes you think about disparity. So maternal sepsis is estimated to complicate 10 cases per 10,000 in the United States. But of course, then we start looking at worldwide stuff, we're talking 261,000 maternal deaths every year worldwide. That's 11% of all maternal deaths. So think of all the undeveloped countries and things like that. Globally, maternal sepsis is estimated at 5.7 million cases per year. It's a bigger problem than what we thought. Helps if I put my glasses on. Okay. So maternal sepsis also, there's some risk factors for them. First one being not ever having given birth before. That's a risk factor. Black race, public or no health insurance is another reason. And then childbirth related stuff like cesarean delivery, any use of assistive reproductive technology. So if they go to the lab and have eggs inserted into the cervix and things like that, that can add to an infection. Multiple births, that makes sense. Treatment of sepsis in pregnancy should follow the basic principles of all the others, okay? The Maternal Mortality Review Committee from the CDC recommends that health facilities have sepsis protocols in place to prevent future pregnancy-related deaths. It's estimated that 63 to 73% of maternal deaths from sepsis are preventable. Let me say that one again. 63 to 73% of maternal deaths from sepsis are preventable. It all comes down to index of suspicion. It also comes down to, paying attention to the patient, not just chalking it up to pregnancy. For each maternal death, there are 50 women who experience life-threatening morbidity from sepsis. It can go on. And labor can further complicate and impact any kind of parameters that we have, particularly lactic acid. During labor, you're going to produce lactic acid. So you can't use that as one of your parameters. So here's some just normal changes that occur in pregnancy. And for my OB girls online, please feel free to interrupt because I'm sure you know this a lot better than I do. But basically, anatomic effects, that's airway edema and friability. When you get further in your pregnancy, it becomes more friable. Your chest gets bigger this way. And it also then widens AP this way, but then you lose your belly. So it kind of counteracts themselves so that you can still get your breath. Your diaphragm's elevated. What's this also called in the IC world? Abdominal compartment syndrome. goes over time, so it's not as acute event, but yeah, this will cause compartment syndrome. And then, of course, your uterus is getting larger. Functional effects of pregnancy, though, you do have an increased respiratory drive, and that starts early on in the pregnancy. You have some changes in your total lung capacity, but you increase your tidal volume, but you reduce your functional residual. And then you have normal diaphragmatic pressure. And of course, that uterus takes up increased oxygen and consumption and CO2 production. Blood gases, late in pregnancy, this something like this you'll see. Remember the functional residual capacity, the volume remains in the lungs after a normal passive exhalation. And it runs normally around 2 liters, give or take. 1.7 is one of the data that I saw in the end of pregnancy toward the delivery time. It'll drop to 1.34 liters. So you don't have that functional reserve. But these would be normal gases in later in pregnancy. Why is the PaCO2 at 30? The breathing rate increases, right? So when you increase your rate, you're going to blow off more CO2. Now, cardiovascular changes, and I find this just amazing that our bodies go through this. I just cannot imagine. We increase our blood volume by 40% by the third trimester. Our cardiac output is going up 30 to 50% by week 25 to 32. And we decrease in our blood pressure, not the MAP. The MAP stays constant, but a decrease in your blood pressure, diastolic pressure will drop a little bit as early as 28 weeks. We have a decreased SVR, an increased LV mass, and LV end diastolic dimension. There's a better way to look at it. So as we go through pregnancy, 0 weeks to 40 weeks, look how quickly we have drops in our SVR and our cardiac output increases. It's within 8 to 12 weeks that we're seeing this, and peaks around 16 weeks to 20 weeks is when that's going to be at its most. But it doesn't resolve back until after delivery. So if you think of your cardiac output going up that fast, here's some actual numbers that you'll see. This is if you had a PA line in, everybody. Your MAP doesn't change. Your wedge pressures don't change, but your SVR does. So systemic vascular resistance runs 20 to 30% decrease. So if we have 1,000 as our starting point, and that's what I've always learned is start at 1,000. If you're below, you're dilated more. If you're above 1,000, you're constricting more. So if we have a 20% decrease, that means for normal pregnancy, you're going to run at 800. Or here be 1,000 is what this obstetrical gynecological magazine said in 1989. So anyhow, we're talking 800. So if you have, that's normal to occur. So if we're doing a hemodynamic monitoring on a pregnant woman, if we're getting systemic vascular resistance of 350, 400, is that normal? No, it isn't. So peripheral vascular resistance also is there, and cardiac output. Look how high that cardiac output is. See, a cardiac output is 6.2. Wow. That heart's working hard. Now here's what happens in the first trimester, second trimester, etc. And don't you love this picture? I found this little picture of beginning all the way to the end. Okay. So your first trimester on your hemodynamics, you have an increase in everything. Okay. But except for your SVR. Even in your second trimester, you got your SVRs down, you're increasing all your other cardiac stuff. And the third trimester, then you have some more LV strain on your heart than what you had before, which makes sense. You got compartment syndrome occurring. It's going to happen. And of course, you'll see an increase in your heart rate, etc. Now, when you first deliver, then within a very short amount of time, you're going to see decreases in your heart rate then, and your left ventricular end diastolic pressures and diameters. Cardiac output's going to come down more toward normal. So after delivery, you should have pretty much return. Now, in the sepsis world, they consider pregnancy-related serious criteria is to 30 days postpartum. In the stuff I'm reading from maternity sepsis, it says 45 days. You'll still have some hemodynamic changes that occur with the pregnancy. I just find it amazing that this happens that quick. You know what I mean? So here's some risk factors for maternal sepsis, and it's not all about its community risk factors are low socioeconomic status, lack of adequate health care, untrained birth attendants. Then birthing condition stuff is C-sections. If you're doing multiple vaginal exams because of changes in pressure or I need to push feeling would be my guess, OB girls. If you're doing a bunch of them, that puts them at increased risk. Prolonged rupture of membranes, prolonged labor, and retained products. So, yep. And then maternal itself is if they are anemic, which they all are going to be, some, okay? Poor nutrition, existing infections of any kind, multiple pregnancy, and obesity. That puts you at risk for maternal sepsis. So here's what Sepsis Alliance actually says. What to look for when you're pregnant or recently gave birth. They give you signs that run through it. Fever above 100.4, foul smelling discharge, trouble breathing, chest pain, not feeling right, not specific stuff. And it's a leading cause of death of pregnancy related in the United States. And this is Sepsis Alliance, and it's a great website to take a look at. Now, you know how we have news in the ED? It's a scoring system to say how at risk everybody is. Say, yes, I know, National Early Warning System. This is maternal early warning system. So then it's based off of vital signs and responsiveness as well as urine output. Anything in the red says call your provider and start on something. That just for any change in maternal, it's not sepsis related, it's maternal deterioration. Okay. And then you tally things up, and given whatever your score is, then it puts you at higher risk for deterioration or early recognition of deterioration. So it's a Muse score. So in pregnancy, though, this is from CMS. Again, like any other sepsis screen, you're going to say, hey, what's the possibility this patient may have an infection? So if somebody's having burning while urination, you think UTI. If you've had, like in maternity world, if you've been laboring for a while and your membranes have been open for a while, that puts you at risk for interuterine type stuff. So vital sign wise are different just because women are different when they're pregnant. We already talked about that. The temp's the same as what we deal with in adults. If you're less than 96.8 or greater than 100.4, then we need to consider sepsis. Heart rate greater than 110. For adults, it's 90. So it takes into the effect the physiological changes. Respiratory rate of 24, if it's over that. And then WBCs are higher in pregnancy anyhow. So you have to go, normally they'll run 12 to 14 normal. So above 15, then you want to consider it. And the band percentage stays the same. So you need to suspect infection, start goal-directed antibiotics right away, start your fluids right away. Now, anytime the MAP's less than 65 and it's not responding to fluids, it's considered shock and treated like such. And this comes from the California Consortium group, and I'll have more on them later, but they are what Jamie tells me is they are the end all as far as obstetric care. And it's a group for women in the California region. So then you have to confirm whether or not it could be sepsis. And to do that, you have to do testing. So you're looking then to see what are ABGs. If they're having respiratory stress, you get a gas. If you go ahead and get your coagulation stuff, your liver stuff, renal, and then lactic acid. Now, remember though, if you're in labor, lactic acid will be elevated. Now, one of the questions is what happens? How quickly does it reserve to normal? It's right away. Once you've delivered, your lactic acid should be back to normal. It's just during the compression part of pushing part that you're going to have an elevated lactic acid. So one positive criteria defines sepsis, right? Start source directed antibiotics and use broad spectrum if you don't know. Get your cultures. Now, is it absolutely necessary to get cultures before antibiotics? In the sepsis world, yeah, it's a good idea. Do you have to do it? Do not delay the antibiotic. Get it in, okay? What the recommended by CMS is if you don't have cultures by 45 minutes in, then just give the antibiotic, okay? And it's okay, even in the real world, to give the antibiotic and then get cultures after, but chances of picking up stuff in the blood is minimal. And then we got 30 mLs per kg fluids. We do that. Yeah, we also do a non-invasive hemodynamic monitoring for these patients. Now, one thing to remember is we can't do passive leg raise with a third trimester mom. It's not recommended. Okay, so you want to keep them on their left side so that baby has a lot of blood getting to them, you know. But they do recommend that. Now, I ran across some care pathways for acknowledging and identifying early sepsis in maternity cases. This pathway came from Wales, and I actually kind of like it. It talks about, are you concerned that the woman could have early sepsis? And it gives you symptoms that you may see. At the history, it's a triage like you do in the ED, flu-like symptoms, unexplained pain, line stuff, uterine infection if you have premature rupture membranes and you might smell. So it runs through those, and then it takes you on down an algorithm. But this is just one example of several. I like the little bomb here on the top. It says sepsis kills. Recognize, resuscitate, refer. I like that one. Anything to help. Here's another one from Ireland. In Ireland, they actually had a big meeting of all hospital folks, and all the folks got together as far as doctors, administrators, that type of thing. And they did a big summit. So the summit was done in 2018. And for adult patients, it actually dropped mortality once they started following these guidelines, dropped mortality in Ireland by 30%. But this is the maternity form of that. Are you able to see it pretty clearly? Not so much, huh? So it says maternal sepsis, life-threatening, we know. And then it goes to, are you concerned they could have an infection? It's the similar stuff we just had, okay? And then it goes to obstetric history and things that are non-related. So they put risk factors of age greater than 35. That's called a geriatric pregnancy. And there's more and more people in that region, you know. Obesity's there, recent surgery. So it comes through some chronic renal, chronic liver, chronic heart failure, all those things. Okay. And then proceeds on down the path. They check the mu score, then goes to Sears criteria. And then if they use in Ireland, take 3, give 3. Take 3, take blood cultures, take blood lab, and look at your urine output. So that's your take. Give oxygen, fluids, and antibiotics. So take 3, give 3. That's a couple of examples of pathway. I know that we probably have them here in the United States too, but I couldn't find a real good picture of them, so I just used these two. So leading causes of death for maternal sepsis. Antepartum, you see the abortion. You have the infection of the uterus, then pneumonia, pyelonephritis, and appendicitis. Intrapartum or immediate postpartum, these are the most common. Wound infections there. For necrotizing fasciitis, usually it's a group A strep that's doing that. And it, you know, we have seen that here in Quincy and in our ICU. So post-discharge pneumonia, pyelonephritis, again, wound infection, mastitis, and gallbladder. So why are pregnant women more vulnerable to sepsis? The intrauterine sepsis. One of the things is the placenta site itself it's warm, it's a large area, it's dark and moist, which bacteria love. So once that cervix is open, that's where they can head up. You know, bacteria goes from the outside in, it follows the vagina on up into the uterus. So that's what's part of that is. Come on in, ladies. Placenta also has a very rich blood supply that leads directly to the main venous circulation. So if you are getting bacteria in there, the chances of it going to systemic is very high. And remember, only the vagina separates the entrance of the uterus from the outside, from the perineum and the vulva. So very small amount of area. Yeah. And then during delivery itself, tears in the cervix, vagina, or perineum during birth is traumatizing tissues. Okay. And traumatized tissues are more prone to infection. Hi, ladies. Please open up, eat. Do. Okay. No, open it up and eat. It's okay. You're not rip off the Band-Aid, right? Okay, you are fine. No, you're fine. So this is general management of maternal sepsis, and I found this. It's been out since 2012. Came from Obstetrician and Gynecologist magazine. So some of the things you want to do is the history part, detailed history, and try to figure out what the source is by history. And then what part of exam, don't skip any parts of the exam. If they just had a baby, make sure you're looking at everything, including down there. Okay. And then of course, investigate, do your lab works, do things. Okay. So it's a nice little sample of general management. Now, one of the things that was always mentioned is that we need to have protocols and we need to have things in place. And part of that is an order set. So we do have a maternal sepsis order set. It's actually buried in the sepsis orders. So when you click on sepsis and bar, you should be able to open up bundle positive, pull that open. And then at the very bottom, you have the different disease states or different sources. You got UTI, you got this, you got that. Maternal is going to go there. It's not in the system yet. It has passed through, and our IS department has done a lot of weird things this last couple months, so they haven't had time to get this in there. But this will give you the exact antibiotics that should be started on a pregnant mom based on the source with dosing. Also set up a stat so it'll automatically start. Okay. There won't be any delays on getting your antibiotics. Now, for those in the OB world, if you need paper copies, I'm happy to provide them. I actually think they will be there in policy stat. So you can pull them from there too. So now what happens? This is me. This was me, still is me. A pregnant patient to the ICU. Oh my gosh. Ouch, right? So what causes somebody to need to go to ICU and out of the OB department? Personally, I'd like to keep them in the OB departments because those ladies know what they're doing there. It's okay, stay there, ladies and gentlemen, I should say. But what may cause somebody to come to the ICU would be hypotension, just after fluids, like fluids are not correcting quick enough. So you're going to have to hang a pressor. Now, does that mean that we can't hang a pressor in OB and labor and delivery? Oh, we can. Okay. We just got to stay there with them. Okay. Respiratory status might be if they're in pulmonary edema, if they need mechanical ventilation, airway protection, any of that. So if their FI2 requirements are getting above 50%, they may need to go to a critical care environment. Okay. Of course, renal dialysis, neurological is significant decrease in conscious level or getting crazier and heck. You know, if they're starting to get overly wild, I should say, that's an altered mental state. So they may need to come to the ICU. And then other things, if you're having organ failure, that makes sense. Hypothermia. Questions on this part of things? So this is criteria for consideration as well. MAP below 65 despite fluid resuscitation. Persistent hypoxia. SpO2 less than 92. Altered mental state. Okay. So I would hope that if they're in the OB department and exhibiting some of these signs, that they get the heart nurse involved to assist them for system in management of sepsis type patient. So one of the good things about a rapid response team, and we all know this, is how are they able to help? Well, you know, it's collaboration. Obstetric nurses know what's going on with that mom and baby. They know how to handle all this stuff. They just need another pair of hands. So when you call a rapid response, you get your friends to stop by, basically. Let's pull friends in. Let's make sure we're hitting all the bases and go from there. They can assist right away, provide early intervention if they need to, and of course, make recommendations. So here's some considerations for pregnant women with sepsis. Vasopressors. Norepinephrine is still the first drug of choice to keep your MAP above 65 if they're not responding to fluids. Now, you may have to add dobutamine in there too, because some people, I don't know what the statistics of it are, but some mothers need to have some heart support while they're in toward the end of their pregnancy. Keep their sugars down below 180. and watch their temperature. You do whatever you need to do to get the fever down or get them warmed up, depending on what you need. Cooling blankets, fever. Because remember, whatever mom has, baby has, but baby has more of it. So if she's carrying a fever, baby's carrying a fever too, which can be detrimental to them. We got to make sure, of course, if their baby's young, at 23 to 36 weeks of pregnancy, then you may need to give some steroids. I'm not an expert on this stuff, and I'll let my OB friends know that. And pregnant folks are more likely to get DVTs. So they have a lot of clotting type stuff. But you also know, and I did this in reading, I don't have it in front of me, but their immune system is compromised because of the carrying that baby. It's something about, I didn't get the gist of it, but they have reduced immune system already, just being pregnant. So I wanted to say, what about team? Well, I hope that if that mom's in the ICU, which we've had them years ago when I first started, in that first couple years of my young nurse's life, they delivered a baby in the ICU. I was not there, thank goodness. Yeah, but no, it was a trauma case, and out of the blue, here comes baby. So we've learned a lot. Thank goodness nothing bad happened. Baby made it. I think the baby's probably about 33 years old now, but so you want to have a big team here. So the team that's involved for the labor and delivery piece and postpartum, of course, critical care physician, anesthesia, L&D, RNs from both sides, RNs from the obstetric area, RNs from the critical care. Same thing through labor and delivery, and then same thing for your postpartum. Now, what do you need? You need to be prepared, right? So if there is a mom with a baby on board, you need to be prepared to deliver a baby, okay? First of all, help is your best bet. OB is your best help. It might be a little louder than that. Yes, like help. But with them, then they should be bringing down the neonatal resuscitation stuff. Now, we do have the pediatric crash cart available that does carry neonatal supplies. So again, but I do not want to be birthing babies, and I don't think any of you guys want to either. Okay. Now, things to think about after you got an ICU patient that's already delivered a baby. What do you need? You need a breast pump. You need to know if they want to have, if they want to be able to breastfeed that child, no matter how sick they are. We want to be able to offer that and continue that for them. Need to have that newborn bonding, skin to skin time. And if you can imagine how traumatic this is for a young mother that's having the best day of her life and the worst day of her life in the same day, how that psychological thing all happens. A few more drugs. Remember that if the baby's on board, no matter what, you got to take care of mom. But everything we're going to give mom is going to reduce blood flow to that baby, which then sets you up for abruption. So if you're dealing with hypertensive crisis with eclampsia, if you have to give medications, they could set it up for abruption. Take care of mom first. Okay. Give them steroids, give them whatever you need. Okay. Mechanical ventilation on a pregnant mom. You don't want to have permissive hypercapnia. Acidosis means acid baby. So if you cannot let them become acidotic. Ideally, you want to keep your FiO2 less than 50, but you may have to go up. And of course, you have your alarm set. Low tidal volumes, because you know you have that compressed lung. You can't get as much as you normally would. And some places say we should do like a pressure regulated, either pressure control ventilation or PRVC controlled, because of the amount of pressure that the moms have. Most of the time, the PEEP settings are going to be higher because they already have atelectasis from compression. Okay. But we want to make sure, again, like anybody, low peak pressures and low plateau pressures are the best. Sooner the better, right? Get them off. Now, positioning. So if you have a pregnant mom and she's in her third trimester, we need to make sure that she does not be supine. We want to get her on her left side, or at least side to side. Full side is great. If you can't get her all the way over on her side because of reasons that you can't, Try to pull baby, manually pull baby off of her. So it's pulled to the left, okay? That way you don't have all the cardiac output problems and compression that occurs when they're on the back. You can put them on their belly. COVID taught us that, and Shanna's the expert. So get a hold of her if you're gonna get a hold of her. Get a hold of her if you need to put mom on her belly. Yeah, that's what I'm saying. You're the expert, man. Here you go. So patient monitoring wise, this makes sense. We're going to do it all this way anyhow in the nursing world and the ICU world. What we sometimes forget about is that fetal monitoring. Okay. And again, our obstetric friends will be truly friends if we have a pregnant mom in the ICU. But and of course, your liberation bundle for ventilator management still occurs. So let's get her off the bed. Okay. In OB, whenever they're seen as septic, there's recommendations. So if you are positive SEP1, so you've got a presumed infection, a couple serious criteria, or organ failure, and a blood pressure in a mom, systolic pressure less than 85 is considered hypotension, not less than 90, but the MAP is still 65, okay? So what should happen is, of course, fetal monitoring is continuous, pulse oximetry is continuous, blood pressure should be taken every 30 minutes, until the lactate gets lower. Now, this is not a laboring mom, obviously. Temperature, take it every 30 minutes, and your output hourly, and of course, continuous look at her mental state. So let's say we do have a baby in the ED, or mom in the ICU that has baby on board. Again, we've covered this. Make sure that you have resuscitative equipment for that baby. Delivery equipment may be needed. Hopefully your friends from OB will come see you. No, they will come see you. Okay. And here's a few pictures of what you might need. So some of the key points I have here is pregnancy induces respiratory alkalosis. It's automatic. They do that. We do not want to have them be acidotics because baby's acidotic. And here's your other goals. So that's the listen part. Now, believe it or not, I got some case studies, which I think are more fun. Okay. So case study number 1, Sarah is a 24-year-old. She's first baby. She's here for preterm rupture membranes at 32 weeks gestation. She's staying in the hospital. She's on 8 days of hospital stay when she says, I'm warm, and her heart's racing. So here's your vitals. If you think of the Sears criteria, temp 97.8, that doesn't meet it. Heart rate 130 meets it, right? Respiratory rate 22 really doesn't meet it. Blood pressure 115/62 doesn't meet it, and her sats are there. Now, believe it or not, when the mom's heart rate's up, baby's heart rate should be up too. And some of the Sears criteria, it does say when the baby's heart rate's getting above 140 at rest, that may be a sign of sepsis. Maybe. Now, this little gal started having contraction at every 3 minutes. Now, thank goodness I'm not an OB nurse. OB nurses on board, I hope you can put in the chat what you'd be doing about now. I can't see the chat. That'll be my friend Shannon. So she began contracting, and for those of you that in the OB department, cervical exam of 380 minus 1. That's where the baby's at. You can't smell drainage. That's kind of what I said. 80% effaced, -1 station, and 3 centimeters dilated. Thank you very much. Okay. The WBC was being collected daily, and we're now up to 22,000. Now that's a Sears criteria for this, because above 15, mom, you get 22. So we have heart rate and we have WBCs. Although the patient had a positive sepsis screen, no confirmatory testing was performed because Sarah did not have a fever and there was no clear source of infection. The rising WBC was discounted as because Sarah had received steroids 4 days prior to mature the baby's lungs. So we'll go on. In the recovery room, so she goes every 3 months, they end up taking baby in the recovery room. Now she shows the signs. Chill, shortness of breath, temps up 101.8, heart rates 120, respiratory rates 36, MAP is below 65. Now she's in shock. Oxygen's applied, rapid response nurse and intensivist at the bedside to evaluate for septic shock. So they went ahead and gave 30 mL per kg of fluids and sent off in organ injury labs and blood cultures. Zosyn was administered because they did not have a source. Although premature rupture to membranes, you probably should consider what your source is. Lactic level was reported at 81 milligrams per deciliter. That's an R81 or 9 millimoles per liter. And your output was low and she started oozing at her cesarean site. So we're kind of in trouble here. So team consultation here. We had a full rapid response team showed up. Patients getting transferred to ICU because they remain hypotensive after fluids. And she received an additional 2 liters in the ICU. She did finally stabilize with the broad spectrum antibiotics and monitoring and was actually able to go home 6 days postpartum. Cultures grew both group B strep and E. coli. Final diagnosis that was found on this patient was septic shock secondary to chorioamnionitis following prolonged preterm rupture of membranes. That would make sense, right? No. Group A is what they test for. They do B, B, and A, both, right? B and A. Hey, OB, what do you test for? You're on chat. I'm just seeing if anybody says anything. B? Okay, thank you. Thank you, guys. Okay, so thank you. Okay. Lessons learned. Okay. This is the Monday morning quarterback in me. Ready? Even though she did not have a fever, Sarah met initial screening criteria for sepsis with the white count and the heart rate. Key lesson is that fever does not have to be present for a patient to have an infection. And a maternal heart rate of 130 is noteworthy. It's above. If you're at rest, not pushing or anything like that, and just resting, you should not be running 130. It illustrates a common mistake that symptoms of young, healthy maternity patients are discounting. So there's no fever, therefore she's not infected. The WBC is because of steroids. The heart rate is because of labor. We do a lot of that stuff, and we do it not just in the pregnant population and maternity population. We do it with all chronic and disease states. Oh, they have heart failure. Oh, they have renal failure. Oh, they have, and continues and continues. So the reason why I said about group A strep, okay, is because this is a fatal maternal sepsis. This stuff goes from 0 to 60, and it grows extremely fast. It's recommended to be checked at 37 weeks in the literature I was looking at. Now, I don't think they do this because it's not as common. If the OB counterparts in the chat want to comment on this, that'd be helpful. So while not all pregnant or postpartum patients with severe group A strep infection, they can get toxic shock syndrome from it. And like I said, that goes from well to not well in a very short amount of time. So I have something now for, I hope you can hear this online. We'll see. This case studies came to me from Sepsis Alliance. How do I get to this? Just hit control and link. Hold control. It works at home. It's because I'm on Teams. Here, we're gonna end. Let me. Oh, okay. That's, oh, I don't see that up here, guys. Okay. Let's get that out of the way. Where'd it go? Yeah.
Second screen,
Oh, okay.
so we can see what you're doing,
But I can't see what I'm doing.
right. So go back to Teams.
Okay, here, hold this. Where'd my teams go?
Well done.
Guys, I'm sorry.
Three Teams.
This one? Nope.
Where's your presentation? Go back into your presentation. Just go back into your presentation.
This one.
Well, like, no, hang on, hang on.
Technical difficulty.
There you go. You can't see it, but they can.
Okay, now
And
you should see.
mouse is over there.
Okay. We have sound. That's the sound that has to come through the computer. Hang on. More. Where's it go here? In the apps? Can't remember.
Your computer sound.
Okay. Right.
Okay. But now, here.
Okay.
The presentation.
Okay. And yeah, you got it. Yay, yay.
Can we hear it though?
We'll find out. Yay. Volume 20. How do I get the volume on?
I don't, yeah. Read it.
This won't help us. We can't hear it. Get back over here. There's something in here. Nope. Thought it was under this more. Okay.
Your settings.
This is frustrating. There's supposed to be. 2 weeks. So I apologize, guys, for you not being able to hear this, but it's worth seeing on your own. It's a 7-minute video from Sepsis Alliance. You can get on. There's several of them that you are able to pick from. It's worthy to see what these poor folks. Okay, now, Shannon, I missed my presentation again. Oh, there it is. It's there, but I can't see it. Here, got it. Okay. So we're coming down to the wire here, and what I have currently in these slides then is more case studies. To include at your normal time. We can go through another case study number 2 real quick, and then or we can stop and answer questions or try to. Okay, the question that T has was, why did they wait 6 months to do the hysterectomy on her with a necrotic lining in her uterus? My guess is that it took 6 months to get well enough to even consider doing it. To even know that she had it, right? Okay. So Dr. Rickelman has joined us for his presentation that's probably following me, and he's helping to explain why it would probably take so long.
I forgot we're doing this.
Yeah.
Hi, guys. So any vasopressor that you expose a person to, you don't know what it's going to do to their tissue. And so certain tissue is going to be more amenable, certain tissue is not. That's why you see skin react very quickly. It's very vascular. Bone has one single vessel potentially going into it. And so over time, that's one of the reasons why she developed her avascular necrosis over time. You don't see that. It degrades over a longer period of time. And so any one of our patients that you see subsequent, and I'm sure Laura probably talked about it, we think that we save these people, and it's 6 months down the road, they find problems out. It's a year down the road, they find problems out. It's 3 years down the road that people find these things out. One of the things which I don't know if you presented, septic shock patients, 3-year mortality after they survive the hospital is 70%. So that's not that they go home and they're doing well. They obviously go to nursing home. They have something else that's happened to them, and then they end up dying in 3 years. So all the things that we do that we emphasize, which are important, 100%, there's more going on. There's much more damage that body has sustained. And in this case, the uterus is extremely vascular, so it probably was able to tolerate a lot of things. But over time, for whatever reason, she developed it. And maybe, someone else could have been through the same problem and not had that problem. It's looking for things. And so she may have put off things and thought she was doing fine. And all of a sudden, next thing you know, necrosis set in, and so on and so forth. So,
Well, and the thing to remember with any obstetrical or any sepsis case, but obstetrical sepsis is, we chalk it up to it's part of the delivery. We lost X amount of blood. We lost X amount of this, and it does make sense. However, you have to be over diligent, I guess I'd say, to think of sepsis when somebody's decompensating.
my worst case,
Your worst case, exactly. And we did have a 36-year-old that passed away in our unit from postpartum complications. So,
we tried for 8 hours to get her back.
mhm.
So
So it does happen, and we're not alone. Here in Quincy, since January, we've had 11 cases of sepsis on obstetric patients. So they're not bad. They're early sepsis. Thank goodness we got people catching it early these days and jumping on it and getting the antibiotics going, because each hour delay in antibiotic is a 7.9% increase in mortality. And these people will compensate up to a point because they're young and healthy. Then when they decompensate, they decompensate hard. So, yeah, just like, well, it's similar to kids. Well, kids will compensate for a long time and then all of a sudden they won't. So, included then in the slideshow is 2 additional case studies that you're free to look through. They came from that California Maternal Quality Care Collaborative. Finally got it all together. So feel free to look through them. I know I'm out of time now, so I appreciate your time and attention. If you have questions on maternity, feel free to talk to your cohorts there in OB. If you have some questions on sepsis stuff, I may be able to help you. Okay, feel free to reach out. Yes, I will get the links in the chat for you. Okay. Thank you very much, guys. Appreciate it. Bye. I get the links.
so